This conference will now be recorded.
So let's go ahead and introduce yourself to one another. And I'll give you a little bit of an overview. IPEN actually has right now 56 members, but they're all on different time zones, and it's quite challenging. So right now, Sandra, are you 8 a.m. in Western Australia?
7 a.m. Well, started.
You're
Yeah,
7 a.m. Okay, darn. I thought the time change hit Australia already. Or does Western Australia not do time change?
Yeah, WA doesn't do time changes.
Well, we've been voting to not do it here, too. But then people are like, well, do you want standard or daylight? And they can't come to an agreement. So IPEN is just an informal um, Indigenous Patient Navigation Support Network. This is our 5th meeting, I believe. And we started recording them just last month. And I haven't been able to get the recorder up on our website yet, but I'm supposed to be meeting with our webmaster next week, and I'll see if we can get it up so people get a chance to enjoy what we learned from the Australian Aboriginal navigation programs, because it was quite good, quite interesting, as as usual. So let's go around and tell people who you are, and for those who are native, to go ahead and identify your tribal affiliation and what you do with patient navigation, please. And let's go ahead and Corey, why don't you go ahead and start? And you're on mute still. Okay.
Hi, everyone. I don't know whether to say good morning, good afternoon, or next day. Anyway, my name is Corey Santos. I'm Apache and Dene, and I've been a supporter of patient navigation programs for quite a few years, as well as I've been a patient navigator at a time. So I support those programs in every form they have in a lot of different communities and settings, including my dissertation was on patient navigators.
Thank you,
I'm
Corey.
here in Colorado now.
Yeah,
I spread my time between Colorado and Minnesota.
Yeah, she teaches in Minnesota also.
Yeah, I'm a teacher, professor of environmental science and indigenous studies together.
Yeah, good. Marilyn.
Hi, I'm Marilyn Rubidoux. I'm at University of Michigan in Ann Arbor, Michigan. I'm a radiologist and I do breast screening full time. That's my entire job. So that's how I know about patient navigation and what the challenges are to just get from point A to point B to point C to point D to point E to point F. It's hard. And also I was in charge of a mobile mammography unit for the Great Plains Indian Health Service for something like 12 years. And patient navigation in that setting is way more challenging. The mobile unit went to up to 16 different sites in the Great Plains Indian Health Service area and served a lot of women. But it's a challenge to get, first of all, to get the mammogram, and then second, when they need to go somewhere else, that's also a challenge when they need to go have a biopsy, and there's just a whole long string of challenges getting a patient through the breast cancer screening to treatment road. It's a long road. Yep.
Absolutely. And Marilyn is also the author of different education games to train, to kind of teach other radiologists how to read films and also how to work with Indian country. And she's developed some other really fun games and done some
Thanks
for the
to
community.
you. Thanks to you. Linda supported it and it happened. Yep.
Well, good teaming, absolutely. Sandra, go ahead and share a little bit about yourself, please.
Oh, hi, Sandra Thompson. I'm based in Western Australia. I actually work in a place called Geraldton, which is in the Midwest. So about 400, oh, I'm sorry, I have to give it in kilometres, 425 kilometres north of Perth. I'm in Perth at the moment. And really my background is in public health medicine. So, but I'm in an academic centre which supports students to do placements in rural areas. So my interest in patient navigation goes back quite a while because we have big disparities in cancer outcomes for Aboriginal people in WA compared to the general population. And so I've been on a long journey with some research in relation to that with some other colleagues. And I had a lovely, so obviously Cancer Navigators come up because unlike many other diseases, it's not only about incidence with cancer, it's about the cancer journey, I suppose, that the disparities occur even after a cancer diagnosis of equivalent stage. So to me, that's all about the health service and how you can support people to access the care. I guess that's just what you were talking about, Marilyn. It's not just getting diagnoses, it's actually about the whole journey. So I think that's the space for Cancer Navigators. And at the moment, our local cancer network, part of the health department, exploring navigators. I'm not sure that they have the model right, but we're doing a little bit of work for them to really asking Aboriginal people what their perspectives are, what's missing in the current services, what would actually help them with accessing and taking up care. So that's just a bit of ongoing work at the moment. So yeah, nice to meet you all.
And I do think I got your handout posted to the website, but I got to check it because I screwed up something else when I was working on it. So for those of you who weren't with us about 6 weeks ago when we had our last IPEN webinar, Sandra and Gail Garvey, both from Australia, shared some articles about what they're doing and new models. And they really had some lovely graphics on their slides to help us understand a little bit more. And they certainly deal with a lot of the same challenges that we do in the States, but we all have to handle them a little bit differently. So it was very, very good, very informative. Mark, you want to introduce yourself? I should say Dr. Emerson. Yay.
Yeah, hi everybody. Mark Emerson. I am an assistant professor at the University of North Carolina in Chapel Hill in the Department of Epidemiology. And so my focus is on cancer epidemiology. So yeah, this is a new role for me. It's been less than a year since my transition. I was a postdoc at UNC as well, and then graduated my PhD in epidemiology in 2019 now. And so, yeah, I would say overall my focus is really thinking about so I'm from Shiprock, so it's really thinking about the community that I come from and the work I'm doing, even though I'm like place-based in North Carolina and in Durham, North Carolina right now. I think overall, like my interest here is, even though I'm more on the research end of things, is thinking about how integrative we can think through a lot of these things and challenges that we work through both here in territories in North Carolina and back home in Navajo Nation and also in New Mexico, and thinking about this issue that everyone's talked about already in this kind of disparities umbrella from detection through long-term survivorship. And so yeah, so I think for me, what's important is really trying to ground a lot of the work that I'm involved in, working with data here, mostly North Carolina, with thinking through more patient outcomes, patient-related issues, thinking about more integrative methods, more mixed methods, hearing kind of these narrative oral storytelling within these data that we see within the numbers as well. while both are important, kind of finding that balance and everything. So yeah, so that's kind of my background, and yeah, I'm really happy to be here. Sorry, I'm a little distracted. I like can't see well, and I can't like when you lose your glasses, it's the worst thing because it's hard to it's hard to actually find them ever. So if I'm kind of poking around, it's so I can just see all your wonderful faces. But thank you.
Well, Mark, I lost my glasses 2 days ago, and my husband found them in the glass case under the car, like in the middle of the car. So I dropped them, and there wasn't any chance of running over them, but it's like I was absolutely lost without having glasses too. So I
When the
get it.
last time I lost my glasses, I was searching around frantically. I want to say for at least an hour, and the whole time they were like on the top of my head. So
Yeah.
I think we've all done that.
Yep.
And Kristen, how about you?
Hi everyone. Right after my introduction, I was able to allow access to my camera. So right after I introduce myself, I'll go ahead and refresh my page and get on screen for you guys. But my name is Kristen Mitchell. I work for Johns Hopkins Center for American Indian Health, more particularly with what we were calling a Cancer Care Project, but we just renamed it to Cancer Education and Prevention. It's a small project on Navajo and both on White River, but I'm focusing on Navajo. I am from and work at the Chinle, Arizona site on Navajo. And so, yeah, so in my position as the site coordinator for that project, I kind of just help to facilitate, the quantitative types of measures in the project. In addition to being the liaison for some of our other staff on the project who work remotely. So that's where I'm at.
Excellent. Well, thank you. And then thank you for joining us. That's great. Kellen.
Hi everyone, my name is Kellen Polinyaptua. I work for the Hopi Tribe organization under the Hopi Women's Health Program. I'm the program coordinator here. About 9 months in, so I'm starting to get to know everything around this organization, and yeah, I just would like to learn a little bit more about patient navigation from other tribes and other indigenous populations, as well as just share some insight of what I've learned through my trials and errors as well. So, but I appreciate you all being here. Thank you.
Excellent. Excellent. Well, thank you all. And I know almost everyone. I guess Kristen's first time you and I have met. He's auditing here. We have to let him off here. Native American Cancer Research Corporation started doing patient navigation in 1994 after I left the National Cancer Institute, and I had been talking with Dr. Harold Freeman, who's the father of patient navigation. And we really learned by trial. I would ask Harold Freeman questions, and he'd say, I have no idea how you would do that in your setting. So let me know how it works. And he's just such a generous, kind, loving man. He was always very, very supportive of everything. He continues to do it. He says, what's happening now? Because there's always something that's different in our community as compared to working in New York in the Ralph Lauren Cancer Center, which is where his program is based. And
This is Ralph Lauren Cancer Center.
Yeah, absolutely. So it's in Harlem, and they have navigators who are totally dedicated to financial toxicity. They have others that are dedicated to cancer medications and helping patients get access to medications. So when you're really, really a big program and well funded, you really can get some cool things going. Whereas a lot of our programs, we're doing everything part time, and we're scrapping to try to get money to pay for everything. Whatever, how it works. So I had sent out some things for agenda items. We were hoping we were going to have somebody from Canada or from New Zealand share with us today, and nobody was able to do anything. So we probably won't hear from them until summer, which will be a little bit easier for them because it's winter when it's summer for us, in this part of the globe too. So I didn't miss anyone on introductions, did I? Okay, I think I got everyone. And a few people are popping in and out, and it's all of our internet, so that's okay. I do want to raise a couple of issues with you, and one is that we're just starting. I serve on a lot of different national navigation committees, and we're seeing so many differences in the pay salary for navigators. Um, and it's an amazing range. So if it's a licensed nurse navigator or a licensed social work navigator, if it is a community-based navigator who is not licensed, and what they're getting. And would you do me a favor and go to the chat box and go ahead and add what's the hourly rate that you pay? And are you able to offer benefits like health insurance, dental insurance? In the States, we also have something called workers' compensation and, of course, retirement. So if you'd put it in the chat session, just so we can start to learn. And we're going to be investigating a little bit more because we're trying to get a Department of Labor code for patient navigation again. We had tried this about 6 years ago, or actually it's almost 7 years ago. And the Department of Labor did not approve the definition that was done. And when we go for it this time, we want to be able to say with a little bit more authority, most navigators, when they start out or entry level, are making this amount. If they're a licensed social worker, they get a higher salary. Here's what they get. And if they're non-licensed, here's what they get. Kellen, thank you for sharing that. And in our program, when we started our program in 1994, we paid $13 an hour, which for that time was higher than minimum wage. And then people went through 6 months of training. And after 6 months, they got $15 an hour. And if they got any type of a degree, so we had some people who didn't have a high school education. Anybody who got a degree, they got a minimum of $1,000 bonus into their salary. If they got a bachelor's degree, they got $2,000. A master's degree with $3,000. Just to try to reinforce how important it is to be able to get academic degrees so that they're free to go in more places and do more things. So that's kind of what we did. So for the others, if you know what your salaries are or anything, if you put them in the chat box, and we'll share that, because I do a transcript and I pull out some of that information so we can build on it. Now, I sent out an article, and I think I sent out an early draft. I don't think I sent you the right one, and I will make certain that you get that. And it is an article that was from and actually I'll start sharing my screen here. And here is Ashtemata. Sorry about that. So on what you're seeing on the screen is this group that's called Professional Oncology Navigation Task Force. Now, what happened in the United States is Biden, who is now our president, and his wife Jill were very interested in cancer because he is a cancer survivor. And they started the Biden Cancer Initiative. And they were doing some really, really good work in this organization. And they had a lot of key national groups involved with it. And then when he decided to run for president, he had to close down the whole initiative. Well, it has been restarted. And this professional oncology navigation group have identified standards, and they're trying to come up with some consistency of how we use terminology in navigation. And this is to make it more likely for us to be able to get a Department of Labor code so that we can pay navigators. We've always paid ours through soft money or grant money. And that really isn't a way for a program to survive. It's a terrible way for a program to survive. So I wanted to make certain you had a chance to ask questions about it. This process went through, I think it was over 6 months of reviews to different organizations that had patient navigation. It went to community-based. So Kellen, like the program that you run, the program that we run, it went through some of our types of organizations. It went through cancer center programs, other clinical settings with social workers in it. And there was quite a bit of debate, and some of it got downright aggressive at time. People saying that's not how we do things. We can't say that that's, that should be a standard or whatever. So the standards are a compromise. So I don't want you to think they're perfect, but what they give us is a national agreement about what the standard should be. Plus, we have two other processes that are going on that might help all of us. And I'm going to show you the draft of the job descriptions document too. So first, and are you interested in going forward? If you're not interested in this at all, I don't have to do this. Yes,
I'm
no?
interested.
Okay. Okay. And okay, all right, I'll grab these slides in. And this is from this professional group, and their acronym is PONT. And you're going to see it. There's a publication coming out in June that is talking about it, and apparently it's being posted on some of the national websites. So when you see that acronym, it's referring to Professional Oncology Navigation Task. And what the objectives are is that we use terms, navigation, social work navigator, nurse navigator, oncology nurse navigator, in so many different ways. And what the professional group is hoping all of us will do is start using some of the same terminology with the same connotation. And then I want you to just kind of see how they're identifying behaviors. They have identified 19 patient navigation standards, of which the majority of these are entry-level navigators. Now, we're going to talk about 3 different levels of navigators. There's an entry, there's an intermediate, and there's an advanced navigator. Example, when Corey worked for our program, for our nonprofit community-based organization, she was an advanced navigator. We have other people who don't even know how to use a computer, and so we teach them how to use a computer so that they can load information when they're out in the field and things like that. So we have all different levels that we've played with. So these were all different groups that originally had worked with the Biden Cancer Initiative. Now that working group was putting in a lot of hours, and they put in over 2 years of work before Joe Biden decided to run for president. And so they didn't want the work to die, and they asked another one of the organizations to take it over. So there were 3 professional groups: the Academy of Oncology Nurse and Patient Navigators, the Association of Oncology Social Workers, and Oncology Nursing Society. And all 3 of those are professional patient navigation organizations, and they are national. And then we had the Cancer Support Community and the Association of Pediatric Hematology and Oncology Nurses, and the Smith Center for the Healing and the Arts. And these are patient advocacy groups. So they wanted to have it balanced to make certain that patients had a voice in what navigators were actually doing to help them in their journey through dealing with cancer or a cancer diagnosis. And their goals is they wanted to improve the quality of services that are provided to people impacted by cancer. That includes both the patient and the family members. And it can also include the loved ones of that. And so they wanted to make certain that they were advocating for having higher quality of care and better health outcomes and clinical outcomes for the patients who had experienced navigation. And then they wanted to have navigators helping identify what was feasible to collect for to evaluate their program and what wasn't. Some of these programs have so many measures and tools. The navigator's spending all of her time or his time collecting data, and that's not the goal of anything that we're trying to do. The number one goal is making certain our patients are benefiting. And then they wanted to make certain the navigators also had a voice in seeing what the results were and figuring out, are there policies that we need to do that would really improve the care our patients are experiencing for this. And this is for all racial groups, not specific to Indigenous people. And then they like to educate all stakeholders. Most of you know I hate that word, but you know what it means. So to educate people about how essential this role is in oncology. So the overall purpose is to identify knowledge and skills. It's to provide benchmarks for measures, of which we're going to link to some nationally recommended ways to measure navigation, and how to help professionals in public understand the role of oncology navigators. And they also acknowledged that the standards that they were developing, they're not going to be applied uniformly. Example, in Kellen's program and in our program, we're not in a clinical setting. There's some things that are in the standards. There's no way, it's not feasible for us to do. And we're not going to be held responsible for something like that. So they have that flexibility in how things are applied. And then they also wanted to make it clear, if people volunteer as a navigator to help a patient in a clinical setting or in the community, wherever they happen to be, none of the standards apply to that. They are looking for paid navigation positions. They're not looking for volunteers in here. So it's like the next 6 slides are just definitions. And what they wanted to clarify is that sometimes we're talking about a professional navigator, and what happened in the United States with the Affordable Care Act is that they really bastardized our term navigation because they were referring to insurance brokers. And that is not what navigators are supposed to be doing. And so we've really tried to pull away from it. And so they tried to clarify. So these are clinical navigators. These are oncology nurse navigators, oncology social work navigators. So what makes them professional as compared to like our native sisters and native brothers, which is what we call our navigators, is that they are licensed. And these professional navigators are allowed to give medical advice, whereas ours are not. We educate and we help with decision making, but we do not give medical advice because we are not licensed to do that. And the oncology patient navigator, and this is a different way to use this phrase from how most of us have done it. And the key thing that's missing in that little phrase there is that this is a patient navigator. They do not have to be in a clinical setting or use a clinical setting. And if you look up here, they can be in a community-based organization. So Kellen, this would be your people and this would be our people in our program. And Mark, I'm not certain what yours are going to be in yours. You're probably going to have a combination of clinical licensed navigators. And then we have like professional registered nurse or oncology nurses. And they have a new clarification of how we're supposed to be referring to them. When I say it, it's like it's really hard for me to do this because I've used our own terminology for decades. And it's a learning curve, so I'm going to slip up too. And then they have the clinical navigator, people who are based in a clinical setting, and oncology social work navigator. Now, for most of you, if you have done any navigation work, you know how valuable this social worker is. Social work navigators just save the tush for so many of our patients in different settings. So those are like full definitions. Obviously, I'm not reading all of them to you. And then oncology navigation is referring to kind of all these people together who are trying to work together through pre-diagnosis, meaning outreach, education, recruiting people into screening. That's one of the things that Sandra's program has been so well known for in Western Australia, is getting people into screening, all the way through end of life. So we're looking at the full cancer continuum when you talk about oncology navigation. And then the patient, they have a broader definition, and it means that it includes the person diagnosed. It can also be their family or their support systems. Now, this is a bit of an issue because if you're dealing with the patient, and the terms that they batted around in the States about 10 years ago is that the family members or the loved one of the cancer patient was a co-survivor. And that didn't go over too well either. And I think mainly what they're trying to emphasize, if there are children with cancer, that children should have some say-so in what's happening with their experience, along with the parent or the legal guardian. So this one's gonna be a few challenges for when we're doing any of this. Now I'm gonna make certain you get all of these slides. And I just copied these from the article, the correct article, since I think I sent you an earlier draft. It may have still even had my notes in it, so I apologize for that. But what they tried to look at with these groups, and again, these went through big debates, is they say all navigators should interact with patients with respect and compassion, and that their primary commitment is to the patient, not to the healthcare provider, and not to the family member, and that they always had to protect the rights, the health, and the safety of the patient. And this, we had some healthcare providers early in the process who said, no, the navigator is supposed to work for me. No, they're not. Navigator works for the patient. And so they really made that very clear in this first standard. And if you glance at what's in here, you can see they're talking about what are the boundaries. An example of some of the boundaries that we had to deal with in our program is that our patients were so excited to have somebody who cared for them. And we usually go to their homes and pick them up, bring them to appointments. We buy supplemental car insurance so that they're protected to transport a patient in their car. And then next thing we know, they're asking if the navigator would clean their house, or if the navigator would do their grocery shopping for them. And there actually are other services that will do that, but that should not be the navigator's role. So it's kind of, there are boundaries. And so some are on here that they discussed in a group. And I just wanted you to know kind of what happened to us when we were first starting our program. We're like, man, she really needs groceries, and I'd like to get them for her, but now with COVID, so many groceries can be delivered, but not to all the places where our patients live, because we live in such isolated areas, or we live in areas where we still don't have refrigeration because there's no electricity. And then we've been emphasizing navigators need to have competencies, the skills to apply competencies. And they are embedded throughout all of these 19 different standards that are in here. And if there's any conflict of interest, they tried to identify it in privacy and confidentiality. Now, some of the standards have one more category that's on the end. And again, I'm not going to go through all these because you're going to have them in your information. But down here, like sometimes they add something if it's important, like here's the qualification of the navigators, that the navigators should have some type of education. And like patient navigators, we really fought on this earlier in the phase, that it's like, hey, we have had people with a high school education who have been just as effective as people with master's degree. But they're saying, well, you may have to allow variance in this. So we were able to get this sentence, into the thing that, that sometimes you have to accept different types of qualifications. And this again is clarifying, like for community navigators, they don't have to have a license per se. And to give you another example, and this is still on the second one on qualifications, kind of what training people should have to have. And then the knowledge, they've got what everyone should need. Let me get to one that has an unusual bottom one. Occasionally they break things out for who's a social navigator and other things like that. And well, I can't find the example I wanted to give you. But anyway, I'll be able to send these to you. Questions or comments about these types of standards? What are your thoughts? What do you think? Think your programs can do this?
For the social navigator component, I completely agree that master's level education, at least having some kind of case study experience and working with individuals, that comes in handy, and I think that would be helpful. But I applaud you for the variance. Yeah, there are some individuals that can perform beyond their high school diploma, and still provide services to the community effectively. So and I think that is a trend nationally in the United States, that with the pandemic there has been less emphasis on education, so to speak, like the criteria of education, but more of the experience level of the um, person coming into the organization.
Yeah, and I think most of you know that we evaluate everything in our program. We want to make certain we're doing something that it works and so on. And we thought when we first started that people had to have at least 2 years of post high school. So maybe it was a CHR that got additional education or training. CHR, Sandra, is Community Health Representative. And they frequently have a high school and they get a technical certification but CHRs have a very, very broad span of what they do in the different communities. Many of them simply transport and they don't provide any really hands-on education, and others do a great job with it, or they take advantage when they're transporting people. They've got them all in the van, and so they go through educational programs with them. But we found the number one criteria for an effective navigator was passion and dedication to the community. And as long as they were trainable, which we didn't have so many issues with that. We had more of an issue with somebody who was at the doctoral level. It wasn't Corey. But, for someone who was a little bit more rigid in their standards on that. Other thoughts? Marilyn, you look like you're thinking.
Yeah, I was thinking about this is a really hard job, and we're expecting people with various sorts of educational backgrounds to be able to do it. Because the thing is, the cancer road is completely different depending on what cancer you have. So there's just a lot of ins and outs to know about every cancer. And if they're navigating all patients with cancer of any kind, it takes a while to, even if you've had education and training and this, that, and the other, the experiences where they learn and where it's reinforced what the pathways are. It's a whole bunch of different pathways, whether it's colon cancer, brain cancer, breast cancer, melanoma. It's just vastly different. And I feel their challenge in dealing with that. Like, even medical students don't understand how all the different cancers are treated a lot of different ways. Each cancer is not even treated the same way. So for example, in breast cancer, there are 6 or 7 different pathways that you go through depending on what your cancer is and what the stage is. So it's a very challenging thing. And I think the navigator becomes more and more valuable the more experience that they have, more than what was their training. So you can have a lot of training, but if you only navigate a patient once a month or once every 4 months, it's going to take you forever to figure out what's going on in cancer. Besides which, there's the chemotherapy issues, which are very complicated to manage and deal with. And then besides which, the treatment of cancer changes a little bit in every cancer every year or two. So it's not even a stable knowledge base. It's a changing landscape all the time.
And I think a lot of what you're saying is why we think people should be paid more, because they are learning so much. To give you an example, we do an awful lot of training, and we'll do it on basic navigation through intermediate to advanced. And then we also do cancer content. So like every year when I get ready to teach information about stomach cancer, almost none of my slides for treatment and treatment protocols are the same. I have to throw them all out and check on the National Comprehensive Cancer Network to find out what the current statuses are.
NCCN, yeah, and that's a very complicated document. And it changes every year.
Yeah, but they have booklets now that they've summarized most of the stuff in. Yeah, right, booklets that are dedicated for the patient, and there's other booklets that are dedicated for providers. And of course, the other thing is that navigators aren't supposed to be working alone.
True.
Oh, look at the average Aboriginal liaison officer salary in Australia is $76,000 a year. Wow, that's great.
That's huge. Dollars?
Yeah, that is huge. That is huge. And we were
$39 an hour. Wow.
Yeah, we had a nurse navigator who travels out during COVID. Her annual salary that she identified doing her work was $200,000 a year. Give me a break. How is that supportable?
I don't know.
Yeah, and that's partially why they want us starting to look at, what are salaries and figure out what is reasonable.
Yeah, that's a little crazy.
Yeah, absolutely. Other comments, other issues, other things you want raised or anything? Mark, you look like you have a thought. Oh, Sandra, go ahead.
Oh, well, it's very impressive, Linda. I think, it's so organized, but it suggests that you have, all these wonderful kind of level positions all working in the oncology space. And I don't think we've got anything like that kind of occurring or anything like that kind of systematic thinking about it. I guess, how those standards operate in practice, as you kind of said, the most important thing is probably the quality of the person and their commitment and motivation to really help and support people. So, I know one of the issues, say, for example, with our Aboriginal liaison officers, one of the things they may find is that they're not really, they're quite constrained depending on their management. And I think we've got better at that over time around the way in which they can work. And as I said, they work in hospitals, so they're not necessarily working across to the community and helping people, doing that kind of whole journey thing. Quite variable again within hospitals, I think, but there's a lot of kind of, I think, risk aversion, I suppose, and kind of keeping them within the walls, because again, there aren't enough of them to go around. So, they're kind of kept in the hospitals, but actually I think what people, the people in those positions often would like to be doing more, where they're actually supporting people over the journey.
Mm-hmm.
Yeah.
Absolutely. And I don't want you to think it's working all over the country. That's why they're trying to do standards. Navigation is kind of being responded to like a fad, and they're taking like people who have no training and say, well, now you're a patient navigator. And they don't know
Oh,
anything about cancer. And we found it was just as bad. We had to do as much basic cancer education for RNs and for physician assistants than we did for high school people who were going through some of our training programs. They just don't get that much. I mean, some of the nurses had a total of 5 hours of cancer education, so they need to be part of the team with the other parts of the health care providers as well. And as Marilyn was bringing up, how different all the different cancer sites are and how many treatments. And it's like I was looking at our NASI Care tool right before I got onto the webinar. And I realized when we look at staging, we had basically 4 stages where you've got things like lymphomas that have 1E, 2E, and they have other classifications. It's like, oh my God, we totally missed it so far. So luckily we got it before we released it, but it is very complex and, a lot of things happening with it. Other comments about the standards? Any thoughts? Okay, and again, I will send you, the handout for that. The other thing that I wanted to reinforce, and I actually got some follow-up emails after another one of our webinars, is about the metrics. Now, we have put the metrics under resources on our website. It's not necessarily under IPIN, it's under where it actually says resources. So some of the stuff is what you can get. And just wanted you to know that these are some of the national groups in the United States that are promoting metrics, because what we found is that we've been doing navigation now for a couple of decades, and everybody is measuring their accomplishments different. There's no consistency, and so we really can't tell how well things are, other than we know overall navigators save money for the healthcare system. And that has been coming out very, very clear, that use of navigators, that one of the outcomes is earlier stage of diagnosis, more entry access to clinical trials with informed choice. We know that people are actually saving the healthcare system money because they're not waiting until they're so sick and going into the hospital for care, because they get help from members of the team. So in 2017, there was a document that was released by AONN. This is what AONN stands for, the Academy of Oncology Nurse and Patient Navigators, and that they really did a beautiful job researching what was done in a lot of different programs. And I do have a copy of the full document, and I looked on the AON website today and I couldn't find the full document on there today. But they said metrics or evaluations, we need to be looking at patient experience, what the clinical outcomes are for the patient, and what the return on the investment is for having a navigator. How do they save money? If it's a community navigator, how do they save money for the clinic where they're referring the patient to go for care? And they wanted to really look if we were able to expand services or to not make it so the patient navigator is responsible for doing everything. They're a member of the oncology team. They're not functioning alone. And where are their limits? And they had this quote: there's a void in the literature regarding the key areas that measure the success of navigation programs, and that will prove the sustainability of navigation programs. Now, we now have plenty of data that shows navigation saves money, it's cost effective, patients have higher quality of life, and so on. And I put a full list of the metrics at the end of the slides because we don't need to go through them. This is a quick summary. And this is just how we group the navigation. There's 35 metrics that they say navigation programs should be collected. So some of these are real clear, how many patients does a navigator handle each month and so on. But the time periods are a little different. For example, when you're doing what are the best ways to learn when you're working with the patient, that's supposed to be collected during intake when you first meet your patient. And if you're looking at different types of education, it should be how many times do you talk with the patient about clinical trials each month? Um, and what are barriers that they're encountering? And are they the same from month to month? Because you're going to hear people say, yeah, transportation is an issue. Well, so what? What are the ways that we're solving and dealing with this? That patient goals need to be assessed, and psychosocial distress screening should be every month. And then we've got a few things like cancer screening. How many people are screened per quarter? And up here, what's the treatment compliance per quarter? And how many underserved or disparate populations are taking part in screening events per quarter? What is the final cancer screening follow-up to diagnostic workup per quarter? So they have different time periods for these. This one down here is per year, meaning that the navigator should go through an annual assessment of what additional skills or competencies have they learned during the previous year. And some of these, like the diagnosis to the first oncology consult, this is the number of business days. And same thing for diagnostic work for diagnosis. That's the number of business days. So these metrics are quite confusing, which is why, and this document is on our website. It's also on the AONN website. They took 10 of those 35 metrics and they tried to help people understand how to use the metrics, because a lot of us, and I got to tell you, I was asking a lot of questions. So Tricia Stukowski is one of the leaders for all of the metrics work that's been done in here. And she's really, really a wonderful oncology nurse and really does a great job reaching out to patient and protecting patients' rights. And I'd say, look, we're a community-based program. How are we supposed to do return on investment measures? And so what they first did in 2017, they identified the 35 metrics, and then they did a special study and they said, let's take 10 and let's see if they can actually be implemented in different settings and different types of programs. So they have programs like, I want to say, I think the Sarah Cannon program was one that took part in here. So it was some clinical settings, and they were just really a variety. But these are the 10 measures out of those 35 that they did. And what's cool about this is that they did things like, here's the first one, barriers to care, because every time you look at a definition for navigation, they talk about barriers to care. And so this one is saying, here's what the measure is supposed to be. Here's what your denominator needs to be in your formula. Here's the numerator. And I'll tell you, before they did this, we're trying to figure out how to measure this stuff. This is absolutely lovely to help you figure out how to collect information and how often. And it makes it very, very clear of how frequently it's done. And so this document, originally they wanted to make certain that they were able to clarify it, and that they also wanted to help work with programs that were working for national accreditation, which they did, and then certification types of exams. And I put just the rest of them on here so that you would have it for your information to actually see how they're measuring it. But then I wanted to make certain that different assessments, like for learning styles at intake is when you take it, that there wasn't like one set type of test or survey or questionnaire that was recommended. They're a little bit more general than that. But they want you identifying patient goals every month and looking at what are the psychosocial needs, or how much distress is the patient experiencing. We like to use the thermometer. And Ruth McCorkle has been doing stress, distress since 1973. Her test is quick, easy to do, really, really nice. Quality of life assessments, patient satisfaction, behavior risk factors, surveillance survey. There's a survivorship supplement to that. And of course, survivorship care plan that's given to the patient at the completion of treatment and what their follow-up care is supposed to be. So what we talked about survivorship care plans with the Commission on Cancer in 2017, they found out it wasn't realistic, that it wasn't fair to healthcare providers, and that patients weren't getting the information. And so they've really softened what it is. And then we also like to transition when people, where they first they talk about my cancer, and then they kind of move to, no, it's the cancer that just happens to affect me. And then they get to the point where they're ready to help other people in the community. And that's when we say they reach a thriver component. And it really is pretty nice. The educational metrics, you're supposed to be doing some teaching on clinical trials education. Clinical trials, we've been teaching clinical, we have a native specific clinical trials curriculum since 2003. And in it, when we work on training our native sisters and our native brothers, we would go through 3 times, and people would increase their knowledge, and then they would, say, okay, now role play with the patient and getting them into the actual care. And what we found is that it wasn't until they actually worked with a patient and they said, I thought I understood stuff and I didn't. And now I understand why we need to go to the clinical trials recruiter, and how we advocate for the patient and how we explain things. So they're very complicated. This is not just an easy thing to jump into. And of course, patient education and so on. And whatever the education topics are, like for Kellen, he's doing breast and cervical cancer early detection. So he's going to be doing topics that are all related to that. He's not necessarily going to be focusing on survivorship. And some assessment tools are really highly recommended, and others are very, very specific to people's programs. Example for literacy, this is how we assess it in our NASI care tool. So we ask, how well is the patient able to read? How well are they able to read a map? And that got into our tool because we realized so many people at the hospital or the clinical setting were handing a map to the patient and say, yeah, you go over there. And if they don't have the ability to read a map, they don't know where the heck they're supposed to do, and they're afraid to ask on what it is. And we wanted to know, what are the best ways people like to learn and understand. And when you select, this is what comes up for the best way. Do they like it visual? Do they like to hear about it? Because storytelling is embedded in all of our indigenous communities. Is it from reading and writing? Is it hands-on? Is it a combination of these? And then also, what languages do they speak and what do they prefer? So like when we're working with Mark's community, which we have had very fluent Navajo speakers, thank goodness, who have done navigation work out on the reservation. The majority of elders all wanted to speak Navajo. They didn't want to speak English. And does the patient need a translator? And if they're in the clinical setting and that navigator isn't available, yeah, they may need that. This is an excerpt of the stress distress assessment from Ruth McCorkle. She has since passed on, but before she left, we got her permission to modify the tool. What we found is when we just administered the tool, if we did not have a time period, that there was no internal reliability on how people answered the items. So if we said, in the last 7 days, how often have you been nauseous? And we kept using in the last 7 days, and we found it really tightened up the information. And then we could still use the scores that she had developed with her tool, and over the years she's refined it. This tool also, by the way, is in several different languages. Anyway, you can look at that. I don't know if, Marilyn, this is an example of the NCCN guidelines for patients. And there is a
Nice.
patient, there's another book that is just for providers. And the provider book makes the recommendations a lot easier to understand than, like you said, their website is so doggone hard to understand. But they have them for breast, cervix, colorectal cancer, multiple myeloma, lymphoma, leukemia, childhood cancers. I mean, it was amazing how many of these they have made that are easier to use and easier to follow. And they're all free of charge. So these are just to give you an idea. This
Wow,
is the
I didn't even know about this.
yeah, yeah,
I've seen and see the guidelines and studied that a lot, but I've never seen this thing, the
yeah,
distress management. That's so awesome because all the patients have distress.
yeah. They all have distress. Yeah, and it's really quite nice, and they incorporate some stories into some of their information, and they're coming up with a health equity tool, and they are including some things specific to Indigenous people.
Oh,
In what they're
wow.
doing too. So that's really, kind of cool. When Marilyn is a physician, like Sandra is, and when you go to the NCCN and look at guidelines, the first 20 pages are talking about all the things they've edited and modified, and you're like, okay, where do I find the actual, results? And that's why these booklets are just so nice
Oh,
to
that's
be
so
able
great.
to.
Yeah.
Yeah, absolutely. And this is their simple list. And this and the McCorkle tool are the two most common tools for stress and distress. And again, it's recommended that these be done every month with your patients. Now, after they're
Wow.
done with their treatment and they go home, and maybe they're not coming back for 6 months, you don't have to contact them as a navigator and do it every month. It's when you have an interaction with them, and if it's been 6 months since I've met my patient, I need to do another stress distress. This takes a few minutes to do. It's quick and it's easy. Same thing with McCorkle's tool that was on the previous slide. It's quick and it's easy. And this is
So
just,
I'm
yes,
sorry to interrupt you. Okay, so that
sure.
previous slide, the distress scale or whatever it was.
Yeah. Mhm.
Is there any evidence that helps patients, or is it just collecting data for us? Is that just information for me to know, and that's how it's useful? But in filling that out, does that have benefit to the patient to fill that out?
Yes.
Because then they're explaining, or at least they're categorizing how they're feeling, and does that
Mhm.
benefit them?
Yeah, and actually, I just did one earlier today. Let me see if I can find it. Hang on, it's near the top of my in-basket. I just did one today, and had, gee, come on, here it is. So this is for an individual patient, and I wanted to print it out to see what it is. And what it lets you do is that once you see it, you're supposed to look at the scores, and if they have definitely moderate, you have to start figuring out where to refer them and where they're having issues, and definitely with severe, even
Oh,
more so. So, like on the one that I did today, fatigue was extremely high. It was a 4, and insomnia was a 4. And you see the scale only goes up to 5. So
wow.
what it lets me do is contact other members of the healthcare team and say, look, she's still having trouble with fatigue. We've got to do something about that. And she got a 3 on nausea. She didn't like the other medication. She just made her tummy too upset. She wasn't throwing up, but she just really wasn't feeling good. And so what McCorkle does in the tool is that you're supposed to take the data and do the next step. So it is not for data collection only. Not at all.
Okay.
Yeah. What else from anyone? Okay, and this is just showing an example of the National Cancer Institute when they had their national patient navigation program. All of the funded programs collaborated, and they came up with a tool that the responses were disagree, undecided, agree strongly, I don't know, and they helped with the scoring. They give you a scoring on here, and what you do as an administrator is this, like we're doing it now with an iPad, we're collecting it on our in Mousy Care. So the navigator is supposed to hand the iPad to the patient and let the patient go through and select these answers for these 8 items. And then when they hit submit, the navigator does not have access to the information. So if the patient wants to complain about the navigator, they can do it without the navigator saying, that Mary Lou, she didn't like me, or anything like that. And this is coming along. It's working okay. And then the rest of the stuff that's in these slides is just giving you all the list of the 35 metrics. And we're not going to waste your time with that because you can look at that whenever you want. Does that make any sense to you about, what's happening with metrics, why we're trying to measure things and so on and so forth? Okay. And have any of, go ahead.
Some of those tools are really cool.
Yeah,
It's really cool.
those are.
Yeah. And I want to say the Pfizer Foundation right now is working on a navigation tool specific to American Indians and Alaska Natives. And yeah, so that's going to be another tool that's going to help us a great deal with navigation. And then they have another summary document that is all on inequities and dealing with underserved populations. They still have not released the one on geriatric populations. That one was finished right as COVID was starting, and then they weren't able to follow up with some stuff, so they haven't released that one yet. So we're going to be getting more resources that are going to help us out, and wanted to make certain, so when I talk about there's things on our website, I have IPIN here, and so far all I have is basic information about how we came, what the name is, purpose, and so on. And then I was hoping to start posting videos in the handouts. And with Jared, our IT guy's help, I'll be able to start doing that. But under resources, there's going to be different documents, and it's actually in two places. Under Patient Navigators. So this has some of the repositories here. Here's Patient Navigator Toolkits. So if I click on this, you're going to see that there's a couple. Here's the Patient Navigation in Cancer Care. And this is like when the navigator's starting out and they don't really know what they're doing. It's only 68 pages. This was sponsored by Pfizer, and it actually is a pretty lovely document. The one on geriatrics is based on this, but it's focused on how our patients' bodies are so different as we age and we're dealing with cancer, and how you deal with bone issues and other things like that, and how you deal with health literacy, and if you're dealing with an elder who also has dementia. So this is a real nice resource. The other one that is in that page is the one, I can find, there we go, this is the metrics toolkit. So this is the one that shows how to do 10 of those 35 metrics. And of course, it's downloading in my nice slow internet location. Yeah, so there's
Linda,
the
can I make a comment while it's downloading? Because it's amazingly sort of thought through and so on, but it does seem like a hell of a lot of different metrics. And is that why you've now kind of got 10 that you're using as key metrics?
Well, in our NASI care, we have all 35 metrics now in our NASI care. But like for return on investment, but we know people aren't going to use all 35. For example, in our program, if we were using the program right now, we probably would be collecting 30 of them. Kellen's program, which we don't have Kellen with us anymore, but he would probably use 20 of them. And if it's like the program that I was just working with down in Arizona, they're probably going to be doing all 35. So it varies by the setting, but which was nice because when they came out with the standards, which are different than the metrics group on it, that they acknowledge the need to have that flexibility. So it's, pretty handy in that case. And a lot of the metrics, like certainly from NASI Care, they have been quick and easy to be able to collect. And the reports based on just what we got this last week, are getting better all the time. So we're happy with that. It automatically generates a bar graph for you. There's a couple metrics that'll give you a donut version if you want, and you can export all of your data, because the data that you collect is specific to your program. And so the data can be exported in Excel or in CVS format so that you can do additional statistical analyses or whatever else you want to do with it. Make sense? Anything? Mark, we haven't heard anything from you. Nothing, huh? Okay, okay. And I want to I'm just going to briefly show you what is, I was hoping we would have this other document ready by the time we met. And it's going to take a little bit longer, but it'll be worth it. And it will be in a peer-reviewed publication. So we published and we agreed on competencies for patient navigation in 2018. And our latest effort is actually trying to figure out if I'm hiring navigators for our program, I want to be able to tell if I need entry-level navigators, which if I have NIH funding, I'm almost always having to look at advanced navigators, but sometimes I have intermediate. So this is the competency, the competency one up here. Let me see if I can make it even bigger here. So I'm just gonna have to scroll down through it because I know you can't see it if it's any smaller. So the competent, well, now it's off the screen. Good, Linda. So here's the competency, and this is when we're really talking about culturally and legally and professionally. What are the ethics? How do we respect sexual orientation? How do we respect different ethnicities, religions, and so on? And the entry level, if I am hiring someone and I know the position I need is entry level, these are examples of what would be in my job description, only in the green font over here on this side for that first competency. If I'm hiring an intermediate, they're expected to have everything that the entry has, but it's higher level skills. Again, still skills that are related to that first competency. And then the third column is the advanced navigator. Again, they're expected to have entry and intermediate. And in general, this is somebody who's newly hired and hasn't had much training. Intermediate, that they've had experience between I think it's 2 to 3 years is how we defined it up here. It's on another one of the sheets. Actually, it's up here. Hang on. Intermediate, you have 2 to 3 years experience. And the advanced is 4 or more years experience. So, because a lot of this stuff you can't learn until you're on the job. And like what Marilyn was talking about is like if you're navigating one patient a month, it's requiring a certain number of hours a year to be considered that you're beyond entry level and that you're already up to intermediate or to this. And so this document right now is going through one of our national committees, and it's including all different types. It has social work licensed navigators. It has licensed oncology nurse navigators. It has community, or what we were calling lay navigators, which now we're calling ourselves patient navigators with the new standards. And they're going through and saying, I don't think this should be an intermediate. I think this is too advanced, or I think this needs to be over here at entry level. And it goes through, there's 7 competencies that are in this document, but they're trying to make it easier for administrators who are trying to hire navigators to be able to hire accordingly and not assume that they can just jump to the advanced level and hire someone. And this document, we should have a revision of it next month with this committee that's on it. And then we are going to be promoting it. And that's also what we want to tie it into. What is reasonable pay for a navigator? if they're licensed and if they're community based, what do we do with it? So this is something that will be coming out, and it will be coming out fairly soon, actually, because we need it out there fast. Oh, and then the other, so we think that's going to be a helpful tool, especially for administrators when they're hiring for a position. The other thing that has come up with our group, and we have not found someone to talk on it yet, is if you are dealing with a patient who is bipolar, or who obviously has some type of mental challenging going on in addition to what they're dealing with their cancer. How do you handle it? How do you handle it in a real life, real time situation, so that you're not creating additional stress or distress, and that you're actually helping to find the resources to help both the navigator and the patient overcome what they're dealing with. If you know of anybody who does a good job with this, would you please send me their contact information? And because and it was interesting because when it came up in the discussions, people were saying, I could have used that last month. I can't tell you, this woman went bonkers on me. And it's like, oh my
You know,
God.
when this topic came up, I mentioned the work of Eduardo Duran, who is
Mhm.
a clinical psychologist that does a lot of work in Indian country.
Yeah.
He's well regarded. He's not very conventional, but he's well regarded by the communities that he's worked in. And he has several books out, but one of them that really is something to look at is Healing the Soul Wound.
Mm.
And anyway, he's well regarded in communities that he's worked in.
But will he do it voluntarily? Does he require, I mean, I know he charges a pretty sizable fee.
Yeah.
Do you know him?
Uh, I have attended a lot of his lectures, and
Yeah.
he
Would
mentored
you
my
ask him?
brother.
Yeah.
Yeah,
Would you
I'll
go
ask
ahead and
him,
ask
but
him?
yeah.
All you can say is no.
Or maybe he has somebody that he can
Yeah.
reference or something.
Yeah.
But I'll keep looking. I'll keep looking and keep asking.
Yeah. Marilyn, any thoughts?
No, no, I've been thinking of a lot of things. The resources to do with this navigation network are really interesting, and I need to jump into them more and look at everything and see what is useful for me and our university practice, which is very large, but I think a lot of this is extremely pertinent and may be implemented in various ways. So,
Yeah. I primarily downloaded the information for the patients. And I glanced at a couple of the booklets that were for physicians or it says for healthcare providers, I think, on it. Or it
yeah,
may just be for providers.
yeah,
So I didn't download those, but I think I downloaded 7 or 8 of them. Just because I had different navigators who needed a little additional help. And it was like we went through some stuff, and it's like, this is a great resource. And it is. They're really good. Have you looked at the Boston Navigation Guide, Marilyn?
no, I haven't really studied much of any navigation issues, which is typical for a physician, right? and
Wow.
and yet I can see it would be really helpful. It'd be great
Um,
also for, especially for medical students. We're not
yeah,
training medical students in this navigation issue. They're completely clueless.
yeah, they're getting, and again, it's almost being responded to like it's faddish on some areas. It's like, well, that's why we have to get a library of
Yeah,
Department of Library Labor Code for
yeah.
this. Hang on, I'm looking to pull
It's a
up
good
something for you
it's a
quickly.
good topic for medical student teaching, which I hadn't thought about before. and
Yeah,
you're
so
telling
it
me
is the Boston Medical College, and I'm going to show my screen briefly so I can, of course, I've got a helper here
Hmm.
again. Okay, let me get to, come on, get over here.
let's see, patient navigation toolkit.
So this is the Boston, now do you know Tracy Battaglia? Have you met her?
No, I do not.
Good
Boston
lady.
Medical Center. Oh, that's
Yeah,
cool.
really good physician. Also a breast cancer survivor, very strong advocate. Now, what they did in this toolkit is they actually combined 3 toolkits into one. So it's real easy to get lost in it, but they have one that's specifically designed for a navigator, another for an administrator, of it, or a supervisor, which could be the physician. So this one, no baby.
Mm-hmm.
This one might be something that you would really like. And I've talked with Tracy about we need a table of contents in here. And actually, I think I put bookmarks in. Nope, not in this one. I've got 3 versions of it, and so I've got it in some and not others. But I'm going to get this one. Did I put bookmarks here? Nope, I didn't put it in that one either. So it's in the 3rd one. Naturally, the one I'm not pulling up. But what they've got, I'm going to jump back further in this. So it's 62 pages. And they tell stories and they code a lot of things that are in it. They do a nice job citing all their references. No, baby. But they've got, so here's the section for supervisors, right, which is probably what the physicians would be most interested in, but it might even be the 3rd one. So they give you these icons throughout the whole thing so that they give you examples, and they're really good on, and here's a cute tool. So they actually give you a survey tool directly in this document, and it's free online. So here's, I don't really care about that one. I want you to get something that's a little more. Here's the list of the tools that they include just in this one section.
Yeah.
So how to introduce yourself. Yes.
Navigators, yeah.
And then they give you examples. They give you the checklist is quite nice in here. So quick and easy, you can kind of say, all right, what are your program needs? How do you actually assess your program? Because the original Commission of Cancer made you do a community assessment every year and a half. I think it was supposed to have been. Might have been 2 years. But, I'm trying to get to one of the graphics. So you can see here's tool. Consider the extent to which your program goals involve activity in each of these domains. Blah, blah, blah. So give you little hints throughout it. Here's the patient flow. Here's an article that you can link right on, and it talks about how the patients kind of get lost in the system.
Yeah.
Here's another little tool. It's really quite lovely. And
so what was the title of this again? What's the title so I can find it online?
Boston Medical Center Patient Navigation Toolkit. And you will see some things that will reference Volume 1, Volume 2, or Volume 3. Don't waste your time with that. All 3 volumes are in the same book.
Okay.
Yeah, but it's very helpful. What else? Okay. What else do people need, or what do you want? Because there's a lot of resources. Anything? Okay. We've been on an hour and a half.
Yeah.
Ahead,
I was going
Corey.
to say, those resources are a good beginning, especially that last one. That's excellent. And I do think medical students do need training because they don't know what patient navigators, who they work for, and what their role is at many times.
True.
So that would be fantastic.
Yep.
Linda, I just want to say thank you again for organizing all of this and bringing us together. And I just really appreciate it. I think I'm going to hop off now, but yeah, I just wanted to say thank you. And I'm really just in this position of absorbing all of this. And yeah, so I really appreciate it. I really am like trying to like get my wheels turning about kind of like overall linking, you know, kind of native patient navigation, just that experience with some of the work I'm trying to do. And I haven't really made that connection yet, but yeah, I think this is a good starting point, like Corey was saying too, for me in like a little bit of a different way. So anyway, I'm just
Sure.
here absorbing, and I'm getting a lot from this and from your experience, and I always just really appreciate you. So yeah, so I just wanted to say that before I signed off.
Sure, and we're all going to sign off. But as you think of resources you need, send me a note, because if I don't know what it is, I'm working with so many different people. They may know a resource that can help you. And the more, you know, we don't need to reinvent the wheel. We need to modify the wheel, and we don't need to reinvent the wheel.
We need to plagiarize the wheel.
Yeah, there we go. Hey, thanks for taking, you know, the last 90 minutes to be together, and everyone stay healthy. You know, COVID's still around. Still be safe, okay?
Okay.
Thanks very much, Linda.
All
Bye,
right.
everybody.
Thank you all.
Bye.
Thank you all.
Bye.
Bye-bye.
Thank you.
Thanks, Corey.